reorganizing and re-engineering the lives of people all over the world. And so, excuse me. And so we feel that it's a special contribution that we're making, and in particular in the area in which we're known for, which is cardiac care. So to our participants, this program was designed primarily with you in mind. And as such, we invite you to take advantage of the opportunity. If at any time during the transmission you have a question, all you need to do is raise your hands. We'll acknowledge you on YouTube, and please feel free to speak. We're asking that you identify yourself by name. Give me first name, last name, whichever you choose. And we're going to give you some bragging rights in that you can just say wherever it is you're calling from. Okay? We would like to know that as well, because it helps to inform what we do here on the program. Also, I don't know that there's too much more that I need to tell you about that you don't already know, so let's just get right into it. We are back with Dr. Dania Ball, and Dr. Ball, of course, is the president of the Heart Institute of the Caribbean and the HIC Heart Hospital, which is located here in Jamaica. Our special guest this week is someone that we have been waiting for quite a while, and now we've finally got her. So let me just tell you a bit about, because she has quite an illustrious list of accomplishments behind her name. And so we are just going to condense it. You can find out more online should you so desire. She's Dr. Chinyere Anyagu, and she's a Deputy Chief Medical Officer at the New York Health Hospital, North Central Bronx Hospitals, and her area of specialty is OBGYN, obstetrics and gynecology. So she's eminently qualified to speak to our topic this week, which is COVID and women, and in particular pregnant women. She has quite an let me just tell you, she's been practicing now for a little over 20 years, and she cautioned me about saying that. but she has been at this for quite a long time with a long list of accomplishments. But I won't really say too much about that. I'll let her expertise, speak for itself. Doctors, welcome. Nice to have you with us again.
Thank you.
Yeah, Dr. Dania is there. Okay, I know she's there someplace. I mean, she will just make a magical appearance in just a while. But Dr. Chinyere, thank you so much for being with us.
Thank you.
I would like to start off by asking you to speak to us about your observations where you are there in New York, because you were in the New York was considered the epicenter of the of COVID-19, and as a matter of fact, it has the highest amount of cases that that was tabulated so far. Now, I'm just trying to get a sense of what it was like, in the middle of the height of the pandemic, when you were there, you were on the front line, from where you sit as a OBGYN. Can you take us inside the heart of it and let us know what it was like?
Well, thank you. And indeed, you are right. New York State actually has the largest number of positive tested persons till date, with a number of over 338,000 in the state, when New York City accounts for about 186,000 of that. So like a little more than half. So if you can imagine, New York City is a little portion of the big state. Indeed, as New York City is the epicenter of all things U.S., there was an extreme concentration of positive patients, and again, hospitalized patients during this period, counting from March 11th till date. there have been over 21,000 deaths in the state. New York City, that's almost 20,000, which accounted for a large proportion of those who were hospitalized and then eventually ended up dying from COVID-19. So it's been a significant impact. And I think all of us must admit that no matter how the predictions and the epidemiological maps had suggested that we need to be ready and prepare, nothing could have prepared us for what actually came to pass. And, you know, hopefully in our lifetime, we won't have to go through it again, because there's nothing that's been similar to what has occurred from 100 years before in the Spanish flu pandemic in 1918. So the predictions had all suggested that there would be a surge in New York City, and the, you know, leadership in government and healthcare all tried to kind of have a little bit of a sense of how we need to pivot to be able to account for the large number of hospitalized patients. We have to look back at what happened in China and Italy. Again, you know, a picture tells more than 1,000 words. So no one, no matter how much you could have been told or been informed or emailed or communicated about this, could really realize that at a point that your hospital would be overflown with patients, that all the hypothetical beds that you had prepared for, that you would have to use all the providers in whichever capacity they were in to take care of patients. We were not going to be orthopedic surgeons or pediatricians or anesthesiologists. We are going to be providers, because really, truly, that's what it came down to. You have a patient and you needed someone, anyone, to take care of them. I think that what this has done is to be able to have us kind of pull back to understanding that as healthcare professionals, that's what we are first before we then come to specialty. And I think also that this was a very enlightening message that was hearkened to by the public. Often you feel like when you're giving a communication that, you know, the patients and the public wouldn't take your message to heart, but everyone listened. The hospital was immediately emptied of all non-emergent admissions to be able to allow the discharges, have the beds available. And if you were not acutely ill, if you did not need to be in the hospital, the emergency room that usually overflows with people coming in just because it's after hours, it changed in a heartbeat. There was no one here who didn't have to be here. Coming into the facility, screenings had to be initiated. In the facilities, as you note, you come in through the door and, you know, you're asked the questions, and everyone was so accommodating. You know, do you have symptoms? Do you have a fever? Have you been in contact with anyone? If you did, can't go in. If you didn't, you have to have a business in the hospital to be there. Patients kind of filtered into, you're sick enough to have to be admitted versus not. Now, we usually expect on labor and delivery, when you come in, that you can have visitors who can come and support you or come and see the baby and, you know, see the new mom, the new parents. And that had to be changed, because to keep up with the control of the transmission, which is by droplet and close contact, in general, so there were no visitors. Only your immediate other could come, and even then they would be screened, and if they have any risk factors, they weren't allowed to be on labor and delivery, because the worst thing you would want is to have someone who's a potential patient, potential person under investigation, to be exposed to a pregnant mom and or a new neonate. So, I mean, the way people were able to accommodate and assimilate that change, which was pretty abrupt. It was like, today you can come, tomorrow that's it, was indicative of how people were able to understand how important it was to embrace public health principles to prevent the spread of this illness. Now, the testing had always lagged behind, unfortunately, in the United States. And if we knew then what we know now, probably we could have instituted screening on labor and delivery from the get-go. That wasn't the case. And as we know, the information regarding this virus has continued to change. We are enlightened more and more as the days go by of things we should be doing. And what is currently in place, which is standard practicing procedure everywhere, is if you come into labor and delivery as a patient in labor, you will be screened prior to you're placed in a room. It's important to identify patients who are positive. And in line with what's been happening all over the country, we're finding there are a lot of people who are positive who have no symptoms. Now, even if you don't have symptoms, your potential for transmission, because say when you're pushing, you know, and you're kind of like really trying to get the baby down and out with the Valsalva, you can have your secretions be transmitted, and you're putting the people in the room, including the healthcare workers, the nurses, the health staff, at risk by transmitting this droplet infection to them. So that it's really important to be able to know the status of a patient who's coming in labor, for you to be able to appropriately use the right PPE equipment. As we know, you know, the PPE processes requires that if you are at risk for droplets infection, you have to have the proper gowning in the patient care areas. If with the pushing in a patient who is positive, that includes the N95 mask, which, and I mentioned that because, you know, you don't want to put the healthcare providers at risk. They're already at risk by being in the facility at the first place. And so PPE is extremely effective. We have seen in our experience that the healthcare workers' positive antibody screening is less than that in the general population. And so considering that you're in a position where you are at risk because you have people who you do or don't know their status, that's important to know that at least using the PPE is able to keep that percentage positivity in the healthcare professionals lower than you would expect being out there in the public. I mentioned that because in New York City, as we know, it's a very dense area where you have a lot of people who live in, you know, you have apartments, you have single units where you have lots of families. So you want to be able to make sure that if you have someone who is at risk or who's positive, you're able to know, identify them, and as they go back into the community, especially in a mom who's had a baby, you can ensure that they have the proper isolation and practices to prevent the spread to more people. So I think that because the virus affects and the hospitalized patients who are more likely to be male and older, this didn't particularly affect pregnant women as much in the sense of being acutely ill from COVID. However, there were women who were positive. There were women who were sick. When you are sick with the virus, and to the degree that you need to be hospitalized, and then to the degree that you need to be intubated, you have a very high chance of having an adverse outcome. And so early identification and triage and addressing of symptoms is really important. The other subset of patients who have an adverse outcome are people who have renal dysfunction, because this issue seems to affect patients who seem to increase the likelihood of patients needing to have intervention regarding dialysis. And so it was really important to know people who have comorbidities like hypertension, heart disease, diabetes. Again, if you looked at the people who got hospitalized, who were sick enough to go into the ICU, and those who eventually did poorly in the ICU, all were affected with these comorbidities and also eventually needed to have been undergone renal replacement, which is dialysis in some shape or form. There are different ways you can do dialysis, which is treatment to address the kidneys being affected. And it's pretty significant if you have this disease and you eventually need to be on dialysis.
Chichi, let me ask you this, because there was a minute where it hit me. And I should say Dr. Anyagu.
Everybody calls me Chichi, that's fine.
Yeah, for those who are not aware, I mean, you know, you both go way back.
Way back. You mentioned that the healthcare providers, serology documented that healthcare providers actually had less prevalence of COVID positivity than the public. Mm-hmm. And I think it's important for us to know that, because I know in Jamaica, for example, there's been some discomfort both on the parts of healthcare providers and on the part of the public about infection as a healthcare, as a frontline provider. And so it really, for me, it's stuck in my mind that if we are properly attired, if we use PPE, and if we follow the guidelines, and if we follow what we know we should do, there really is no need for us to be petrified of potential infection any more so than we would what we need to do.
And, you know, I mean, there are, you know, people get fixated on the things that are less likely to be areas of transmission of infection. They're worried about their shoes. They're worried about their hair. They're worried about their clothes. You know, yes, there have been reports that you could track virus on your shoes, and people were recommended in the military, because we have the military here. They were involved in the response that we required, that occurred. It's less likely because, you know, you don't really touch the bottom of your shoes. And the virus usually doesn't go up. A hair coverage is not part of the CDC guidance. It could go on your clothes, but it doesn't last there for long. And the practice of, you know, donning and doffing appropriately with the gown and gloves, you take that off before you leave the facility. A lot of times the scrubs that are provided are decanted within the facility so that you don't have dirty scrubs going out. All these of what you want to do to elevate your risk. But the most important decrease in risk, the most important thing, that's not even talking about the mask and all that, is social distancing and hand washing. Because if you really watch, sometimes, you know, I see people using to touch walls, they're shaking hands with others. It's not going to be effective if you don't maintain that. And you can do a little test yourself. Just rub a little colored glitter gloss on gloves and see how quickly it's all over your body. You have to wash your hands. Doesn't matter where you are and what you're doing. You have to wash your hands. And if you had to choose between washing hands and sanitizer, wash your hands. 20 seconds, all the fingers, and you're more likely to do better and decrease the likelihood of transmission than wearing all the different things that we see people wearing. There had been a concern about having adequate PPE. It was a real concern because if you imagine, the supply chain is an issue.
Right.
Things,
I'm sorry, could I ask you to just explain PPE for us?
PPE is the personal protective equipment. So that includes the masks, you know, and there are different kinds of masks. There's a surgical mask and an N95 mask, the thicker one that you use if you're at extreme risk with aerosolized procedures, and then just the face mask, which is like this. Uh-oh.
Uh-oh. I know, right?
Can you see me?
Keep talking, Chi-Chi. We can hear you.
Okay. I'm showing the little mask. So this is what the mask looks like. It's telling me to register, but I'm just going to keep going.
Yeah.
Okay. This is the mask. This is a surgical mask, you know, which is different from the N95, which I don't have one here because I didn't really
have one, so I can show that if you give me just a minute. Okay.
Okay. It just so happens.
It just so happens. And N95 and looks kind of like this. And the difference really why it's N95 is pretty much 95% of bacteria, viruses, external, you know, potentially infectious agents are blocked by the mask. There are even specially fitted ones, you know, they have things, respirators that they actually fit and make sure it fits to your face, and that, you know, when you're breathing, you shouldn't be able to feel the breath come up, for example, if you have glasses to fog up. So there are levels, as in everything, there are levels.
Right.
Okay. If I could just get back in here, Chinyere, I'd like to find out about when it comes to, you know, what are the issues for women who are pregnant versus women who are not pregnant? as it relates to COVID-19?
Okay. So, fortunately, if you were more likely to be affected, either test positive, get hospitalized, and or die from COVID-19, you're more likely to be a man. Not fortunate for you, fortunate for us. Pregnant women do not get COVID infection more likely than the general population. They do not, as far as what we know regarding the virus and what has happened so far. However, pregnant women are more at risk for getting viral infections in general. So precaution needs to be taken so that they don't put themselves in situations at risk, as in being exposed to potential ill people or people who are persons of interest, meaning asymptomatic, undiagnosed people who are out there. In New York City, that's very relevant because we know that the prevalence of this in the community could be over 20%. That means for every 5 people you meet, 1 person has it. And because the prevalence is so high in the community, because, you're out there walking around, you don't know you don't know how the air has circulated or not. And just to decrease the likelihood of you getting it or giving it to people, the community use of the masks has been advocated. You go out there, everyone's wearing their mask. You go into the Uber, you're more likely to be in a car that opens without you having to touch anything, and so on and so forth. Limiting a high-risk situation in pregnant women is very important. What do I mean by that? So if you're pregnant, we know that you're not at increased risk, but you are at risk. So you want to not be in a riskful situation, which could include going to the hospital, right? Normally in pregnant women, we see them every month and twice a month and then once a week. Not anymore, not in COVID time. What we have done to try and improve the safety of the patients who are pregnant is that we have a very detailed televisit that is done at the intake of the pregnancy. And you want to, when you realize you're pregnant, we try and determine to make sure all the issues that would be needed to be addressed, that normally requires a 1 to 2 hour visit in the hospital, is done over the phone. And then when you come into the hospital, it's planned and very well plotted out. So when you come in, you get your blood work, your ultrasound, you get everything that you could possibly need that would normally take 2 or 3 visits in one go, and then boom, you're out, because we don't want you in the midst of anyone who could potentially give you this illness. That includes not waiting for long times in the waiting area, not coming in if you do not need to come in, having your medication sent to you, getting consultations by a televisit way, or consulting with the specialists by e-consults if needed, so that it's more patient-centered and it kind of emphasizes safety of the mom. For patients who have been ill, and they have been pregnant patients who were ill, we like to leverage technology to be able to make sure that we also keep them out of the hospital, because even if you have COVID, the odds are you're less likely to be someone who's hospitalized. More patients are sick and home than sick in the hospital. So if you're not sick enough to be admitted, we want to make sure that we know how sick you are. And if you get worse, and this is really important, I want us to emphasize, and everybody, remember this: if you get worse, you need to be in the hospital. Don't be sicker at home. And this is an important lesson to learn, because we found out people were so scared to come in. You have people die at home for not knowing better. So there's certain warning signs that you have to look for: increasing shortness of breath, difficulty breathing, feeling a sense of being kind of suffocated, coughing, high temperatures. So there is an electronic screening tool that was developed, and when patients are discharged that are positive or were ill in the hospital, they're signed into this program. If they it's a platform, you have to sign in and consent to it. And you get put onto an email text messaging that checks on you every day. If you're fine, no problem. You just get 1 text a day to see that you're okay. If you have symptoms, you're checked on 2 to 3 times a day. And if you give a reason that you need to come into the hospital, it tells you do not pass go, you need to just go ahead and come in. So that way you don't get to the point where you're so sick that you can't be seen in the hospital. There's something called the happy hypoxemics, where your oxygen is so low and you're kind of like, you know, you look like you're fine and everything looks fine, but you're really so sick that the next thing you know, you need to be intubated before you collapse. And we don't want you to be that sick, especially if you're pregnant, because you're not just affecting you, it's also affecting the baby. And a lot of women, the last person they think of is themselves. They think of everybody and everything. But, you know, you can barely breathe. We need to focus on you at this point, not your mom or your husband or your neighbor down the street. And that's kind of really important. Self-care is extremely important.
Let me ask you a question. I'm sorry, Michael. Listen, I'm just hijacking your thread. Let me ask you this.
Go ahead. I'd love to hear the experts converse. Go ahead.
How would you go through your differential? We're in the midst of COVID, and of course, everybody's panicked about COVID, but pregnant women have pregnant women things.
Yeah.
So have preeclampsia that becomes eclampsia, and they can have shortness of breath.
Right.
And, you know, we have people who have, you know, atrial septal defects that have been undiagnosed, or, you know, whatever holes they have in their hearts that pre-exist and have been undiagnosed. And so now you have somebody who is showing up and they're short of breath. And what is your approach to saying, okay, this person is dyspnea, this person short of breath, this person short of breath, breathing fast, for the people who are not medical. And this is, let me go through my differential versus just assuming this is COVID, because 20% of the population's walking around with COVID.
You know, Dania, I gotta tell you, the sad true fact is, it's unfortunate. We're gonna have some misses here, because even before the patient gets to us, which would be the pathway for care, anything that is COVID-like is COVID until proven otherwise. And you know, it's the truth of the matter. I've often wondered, there have been some misses, some significant misses. We have patients with situations that under normal circumstance would have been diagnosed easily and proceeded to immediate care. But here we are in a pandemic with all the services shut down, no preventative care, no elective visits, and basically you're either COVID or not COVID. Essentially, that's pretty much what it is. Anyone who has any respiratory symptoms is considered to have COVID until proven otherwise. Right or wrong, that's what it's been, and that's been the only way to triage, because aside from the extreme fear the public has for whether or not a person is COVID, there is the true fear. And as we know, a lot of healthcare professionals have died. Healthy people who've been exposed at work, through work, from work, have contracted it. And at this point, we don't really have clinical predictors that can tell you you are at risk and you're going to get it, and you're the one who, you know, that looks like allergies is not allergies, is it? And so I think with time, we're going to know more. But at this time, because it's so imprecise, the science is new, there's a lot of misinformation and lack of information. The triage tool included delineating the COVID status, and everything else kind of fell to the bottom. And I do think also the fear that's been associated with contracting it and getting sick has also affected some of the choices that have been made. A couple of studies are coming out, and it's showing that patients, women who are COVID positive, are more likely to be delivered operatively than not. There's still some more information that we will be getting, but in the small series of information we have so far has shown people are afraid to be in there. There may be prolonged labors and what have you. So I think, you know, there's still more information that we're going to be getting to help us assess better. I think testing is more available, and that is very helpful, although the testing is not 100% sensitive and specific, and I like to emphasize that. So having a negative test, if you have symptoms and a COVID-related diagnosis or illness, means you have it, whether the test is negative or not. We've had to deal with that often. When you tell patients, yes, you know, your test is negative, however, I still think you have COVID, because The test is not 100%. The test is not as great as it could be, but it's pretty good. But you cannot ignore the fact that if you have somebody in the middle of May walking in with a pneumonia and evidence of COVID-related illness with a negative test, the negative test is less relevant to me than the fact that you have a healthy person in May having pneumonia in the setting of a pandemic. You have to put all these things into consideration.
And it goes back to Bayes' theorem, right? Pretest probability. If it, you have everything going for it, even a negative does not rule out
the disease.
You know, COVID has, it has been a game changer in a number of ways.
Oh, yeah.
And as awful and as terrible as this condition is, going forward, can you see anything coming out of this experience that will not change in terms of the way OBGYNs relate to women who are pregnant?
I think OBGYN and healthcare will never be the same. And I think that as difficult and as challenging as this has been, creates enormous opportunity in our ability to be able to step back. Like, why do we do what we do? Like, who said you have to see a woman 13 times, and if you did, that's what care is supposed to be? We have been working on the guidelines and the principles that have been set before we were even born. That's medicine and the textbooks, how we do it. This is a game changer. We can wipe the slate clean and start afresh. So if we can take care of women, seeing them fewer times, keeping them out of the hospital, hell, what if we even take the care to them at home? I think there's enormous opportunity that exists in us being able to create a new normal, a new paradigm that had previously been tested, and reset the whole healthcare. Like, I'm actually a little excited. Things that we could never do, things that would never happen. It was like in the middle of COVID, it's like, we do it this way, why? Change it. And it's changed. Televisits even, look at how much more facilitated it is. Who knew you could see your patients with televisits and be able to keep them out of the hospital? And if time shows that the care is good and as good, there's opportunity there. There's an ability for us to be able to focus on the things at the level of intervention that you need to, and cut away all of the distractions of people having to come in and get things done that may not necessarily change their outcomes. I think women historically are very good utilizers of healthcare, especially in pregnancy. That's the only time they truly take the time, present themselves, not necessarily for them, but for the fact that they have a baby that they care about, that they put ahead of themselves. And I think that anything that would make this process easier, more practical, more accessible, more convenient for them would be helpful. I think coming out of this, we may have, ways that you can assess the fetus by remote. We may have ways that women can have their medication sent to them at home a little bit easier. They don't have to go stand in line in the pharmacy, go park and, do all of that. We may develop, maybe birth control in the United States can go over the counter. I mean, it's difficult if you have to come into the hospital to get your birth control. We've been talking about this for ages. Maybe this is the time that we decide that the risk of having an unwanted pregnancy and coming to a hospital to potentially contract COVID outweighs the risk of getting a verbal consent or talking to a patient for 30 minutes to tell them that they could have complications from medication they choose to take. So I think that there are a lot of things that would change. I think that we're learning a little bit more about transmission. So far, there's really not a lot of information about vertical transmission. It seems like it's less likely. I mean, there have been some reports that require require us to look further. But
and vertical transmission for our non-physicians is pretty much mother to child.
Right, mother to child, yeah. In utero, through the vaginal canal or through a C-section, that doesn't really happen. And so if a baby, and there have been some reports of babies contracting COVID, it possibly could be contact from after the delivery. So we want to make sure if a baby can get COVID after delivery, we got to try and make sure we hone our practices to prevent that from happening, no more kissy on the baby. You have to wash your hands. Kind of, you don't know who's positive or negative. And until we know at the time with the test that is sensitive and specific enough, you don't want to have a baby exposed to the potential possibility of getting it from an adult that's undiagnosed. So there are lots of ways things will change, I think. I think it's interesting to see what the next few is going to show.
Right. In case you just joined us, by the way, let me just say that our very special guest this week here on, COVID-19 and You is the very celebrated Dr. Shineri Ayago, and she's OBGYN. She's the deputy chief medical officer at New York Health Hospital, and that's in North Central Bronx, which of course is where the epicenter of this COVID-19 is really wreaking havoc. And she was there in the middle of it all at this time. If you have any questions, please, this program is about you, so please feel free to just raise your hand, and we are standing by to accommodate your questions. We also have with us Dr. Dania Ball. She's also very well known here, not just in the States, but here at home in Jamaica. And together, they're really just sort of giving us an amazing insights into this particular condition as it relates to pregnant women. I wanted to ask about how does family medical history, if at all, affect risks for getting COVID?
So basically, COVID is not transmitted genetically. It's transmitted by transmission from droplets. So you have to get it from someone who either has it by their secretions and you being closer than 6 feet to them, actually probably less than 3 feet. So if you're 6 feet, you're less likely to have the transmission. So it is an infectious, it is an infectious agent that you acquire by contact. Having said that, women are less likely to be affected. Men are more likely to be affected and/or get hospitalized and/or demise from it. There's a couple of situations that are strongly correlated to getting it, meaning if you have chronic illness, a lot of the patients who end up being hospitalized have underlying illness, including liver problems, lung problems, asthma. They could have been smokers, could have heart disease. There's a very high proportion of them who have underlying heart disease, which may or may not affect their kidney function. That puts them at risk also, and diabetics. So if you have chronic underlying illness, and if you're older population also, more likely to have all these comorbidities, more likely to contract COVID, you're at risk. And in these vulnerable populations, we are recommended that you try as much as possible to stay away from situations that could increase the likelihood of you obtaining it, meaning when you're at home, you don't want people coming to your home or house that could be potential persons under investigation. You want to be very far away and maintain social distancing from anybody who is ill. And we want to keep you out of any situation that could put you in potential contact with patients who you could acquire it from.
Yeah.
It's felt that men who are more likely may have an increased predominance of the ACE2 enzyme, which could increase the likelihood of them getting it. But per genetics, it's not genetically transmitted.
Okay. In terms of, you mentioned earlier, just about the start of the program, that fluids, when the attending persons have to be careful about fluids because there's a likelihood of contagion there. What about, internally for a woman who's pregnant? What about the fluid? If she contracts the disease, is the fetus at risk?
At risk. So far, we are not seeing that there's a transmission from a mom to her baby if she gets it. We're not seeing that. We're seeing if the baby gets it, the baby would acquire it after having been delivered and more likely from a contact. So a lot of things have come up like, should you breastfeed your baby if you have it? Breastfeeding has a lot of benefits, including a lot of immunoglobulins and things that help protect the baby from other infection. And so separating a mom and not having the baby breastfeed from COVID requires a very detailed communication between the provider and the mom to have an understanding of the risks and benefits. And currently the CDC recommends that if you are COVID positive, you can breastfeed your baby. You just need to wear a mask. And I know that's a hard thing to do with the baby. You know, it's almost impossible to do. You have to wear a mask and maintain very strict hand washing procedures to prevent transmitting it to the baby. It's difficult, but it can't be done. And we're doing it. I mean, initially the knee-jerk response of separating the mom and babies could do more harm than good. So that's a pretty detailed conversation to have with the parents to come to the right answer.
Michael.
Just, get myself unmuted here. All right. I know that our Dr. Edwin Tullery has been trying to reach us, so I'm going to ask Carrie if she would see if she could facilitate his entry. Thanks. A pregnant woman is carrying, it's not just about her life, but also there are additional lives on board, okay? You know, there's a fetus and sometimes one or two as the case may be. In the treatment of such a mother, are there any special considerations that are necessary?
Yeah, absolutely. You know, I think that we've been fortunate in that COVID disease, and especially like the critical care intervention that is needed for an acutely ill mom who has COVID, is not common. It's a rare thing, and it's a difficult thing because when you have a patient who is pregnant, depending on how far pregnant they are, you may or may not have to consider the fetus in her viability. So if you have a mom who's very early pregnant, it doesn't really affect much. But if you have a mom who's, say, 7 months pregnant, you know, pregnant enough for you to worry about whether or not her being so sick would affect the baby, you're going to have to monitor the baby's vitals while you're treating the mom. And in the cases where the mom has needed to be put on external ventilation, that means put on a ventilator to breathe because she was so sick, it's really important that you do monitor how the baby does, because on occasion we've had to consider whether or not to deliver the baby early with the C-section to have a better outcome for the mom and the baby. You don't want to do that because delivering a baby premature has its own set of complications that you may have to, you know, contend with. But it is something that you may have to consider in situations where there's the organs are affected more than just one. So the patient is so sick, you're worried about them potentially getting so sick that they may not survive it. And or if you have a situation where the mom requires so much medication, you're not able to ventilate her effectively with the machine, and then you're trying to decide, would she be better off if you took the baby out so you can give her oxygen better? So these are all considerations that are very difficult, but have to be made. And again, like I said, fortunately, this does not occur often in women because they're less likely to be affected by the disease.
Yeah, we have a live question here, so let's get to it. Hello, you are on. Please go right ahead. Okay, we have a question. Remember, when we let you in, please just state your name and where you're calling from and your question. All right, so it usually takes a couple of seconds before it warms up. While we're waiting to do that, there was a question about menopausal women. Mm-hmm. Of course, you know, once you, let's say you're at work or you're going into some establishment, your temperature is being taken. You're in the throes of a hot flash. Mm-hmm. Talk to us about that.
So, you know, I mean, people have asked me a lot of questions, but no one has ever raised a question like that. But I have to tell you,
I'm a considerate guy.
Even though the woman is feeling hot and is having a hot flash, it's a vasomotor reaction, not necessarily a physical one. So in more cases than not, in this situation, if you took the temperature, it would be normal. But I gotta tell you, it's gonna cause a lot of commotion if you walk in there and you have a temperature. You're not gonna get away with the hot flash. You know, in New York City for sure, you are not getting away with the hot flash. You're gonna have to be strong.
Okay, so this one's kind of up my alley too. So Chichi is right that it is a vasomotor response. Now, temperature actually skin temperature can rise 5 to 7 degrees. However, we have to remember that hot flashes, come and then they wane. So you're not staying hot. And core body temperature actually does not change. And so if we're checking core body temperature, you should stay right there, 98.5 or Celsius. I never can think of Celsius. That's what training in the US does. You just think in Fahrenheit.
Fahrenheit.
You should stay there. Now, for women who are concerned about, oh, I'm having hot flashes and that's the thing, wait it out. If you are concerned at all, your hot flash is not coming to stay. Trouble don't last always. Give it the moment for it to go away. And then by the time you get to the front door, you get inside the building, anybody checking your temperature, it should be perfectly fine. So if you are having a consistent problem, you cannot necessarily attribute that to menopause. Menopause is not your answer.
Okay. For women who are considering freezing their eggs, are there any particular considerations there?
So all conception needs to go on hold now. That's the recommendation. There's too much at stake. There's just way too much at stake. This is not a good time. There's so many risks, and if you're going to embark on the need for assisted reproduction, it's going to require you to go into the hospital. That cannot be done by televisits or at home. And so all the king's horses and all the king's men have come together, and the consensus is assisted reproductive technology and techniques currently are not a priority. They're elective. For you to be in a healthcare facility right now, it has to be urgent or emergent. And even as we're walking through, so currently we're still in a lockdown, as we're walking through trying to reopen, it's a tiered process where you have to kind of take the more urgent processes up front and deal with those. And as you kind of get those worked out and solidified and addressed, then you kind of get to a point where you go to the less urgent. And this is, this causes a significant amount of stress and concern for people who have been gearing towards a certain outcome at this time. And I mean, hopefully within the next several months, we will get out of this. But if it's a choice to start a family now or to conceive, probably now is not the best time.
This is such an excellent question. I want to drill down on that, Chi-Chi, because so for everybody, yes, I know I'm supposed to be on this too, but I'm fangirling right now. Let me fangirl. What if you're in Nashville, Tennessee, where we haven't had that huge surge. We haven't had, we're not the epicenter. What if we're in Kingston, Jamaica, where we have 500 or so cases island-wide? What if we're in Barbados, where the impact hasn't been as great, or we're in Trinidad, where we're doing all the right things, we hope, but we haven't seen that influx of, we're not at 20% of the population. That is prevalence. Is your advice the same in terms of conception and elective fertility procedures?
That's an excellent question, Dania. And actually, in our huddle, this came up because, again, as you know, in New York, there's a lot of travel, a lot of mobile population movement. So the first thing is, if we were to know then what we know now, one of the things we would have done is to believe what we were being told about the epidemiologic projections. That's number one. I am such a believer. I am like, just tell me what the predictions are and I'm going with it. Epidemiologic tools have predicted pretty much with certainty, and they're using the duplication of the virus and movements and all that, where the virus is going to hit. Believe it. So if you're planning to get pregnant or have a family, the first thing you should do is to look at what the prediction is saying about where you plan to be for the next year. That's number one. What does the prediction suggest for where you plan to be? Because the predictions really, truly, if we had been paying attention, we should be bang ready on it because they were telling us this 10 years ago. So that's number one. Number two, you want to decrease your risk as much as possible. Some things you have control over, some things you're not. We're not men, so you can't control that. You're a woman, you control a couple of things. Some things have been associated with adverse outcomes. Number one, obesity. The patients who didn't do well were overweight, they were diabetic, they had chronic morbidities, they had all these things. To some degree, you can modify. Some things maybe not so easily, but you should modify your risk as much as possible. I would say lose weight, get screened, and you can do that by a televisit and limit, but try and go to your doctor and make sure that any pre-existing condition you have is identified and addressed. What's a pre-existing condition? Heart disease. We found there's an overall increased mortality in patients who had underlying heart disease. And you know what? They may not even have known it. So you have patients in the ICU. You know, I got to tell you this story. We had one of our volunteers, and we had to rely a lot on volunteers. People went through, the governor called and got volunteers and had them credentialed for disaster privileges. And we had some wonderful people come from all over the country to volunteer. We had a cardiologist who came, nice guy, and he volunteered. He was covering the unit. And, you know, he was like, you know, why don't I just do echoes on everybody? I was just like, who are you? And can you come work here for real? I was like, you know, I can use the Sonosite. I'm like, okay, so I'm like trying to figure out, okay, we got to get you an echo machine. She's like, no, I'll just use the Sonosite and you're like, anybody. So he goes around and he's like doing his echoes, and he echoes the ultrasound of the heart. And, you know, believe it or not, and, you know, this is not a scientific study or anything, but a lot of the patients who were in the ICU that were that sick, they had issues. They had problems that show they had hypertension for a long time. They had, some of them had heart failure. The patients who had kidney problems, kidney failure, also had cardiac problems. You know, some of them had fluid in their lungs. It was kind of illuminating that a lot of the people, and not all of them that got sick and seriously sick from this, had issues that hadn't been dealt with. So I would say you need to be at the tip of your game as much as you can before you embarked on this journey. If you are a diabetic, handle it. It can be handled. If you are at risk and you don't know, go get screened. If you're hypertensive and your blood pressure is high, handle that. Take medication, lose weight, exercise, do all those things. So that's number two. So decrease your risk. Number three.
Stick a pin right there. Wait one second. Like we'd say in Jamaica, stick a pin. You know, it's one of the things that I have been saying, and I would probably say we've been saying for a while, in that, especially in, I want to extrapolate some of this data to the Caribbean, to the West Indies. I know New York has a huge West Indian population. We're still talking the same language, and a huge African population. We're still talking the same language. But we've been saying for a while that, especially in Jamaica, where we had quite a high incidence early on with rheumatic heart disease, and, a lot of valve disease as children, much of which is still undiagnosed, that pregnant women, an echo, easy enough to do. There is no risk to fetus or mother, that you should almost consider that as part of your armamentarium, because here again, Bayes' theory, high pre-test probability that you might find something valvular, that you might find something congenital that we've just managed to
overlook, or you survived.
We've survived it. And so now, though, we're going to put an enormous stress on the body, and shouldn't we know these things? And so I got a little fascinated when you said that, you know, the governor brought a cardiologist, and here he is, and he's like, why don't I just do an echo on everybody? And so I kind of wanted to drill down on that a little.
A lot of these unqualified men who are weighing in on this thing. Listen, we haven't quite a number of persons who so we have some live questions that we'd like to take. So let's do that right now. Okay, so Carrie, could you just acknowledge our next participant. Go ahead with your question, please. Hello, Jason. Okay, I'm not sure what. All right, so here's a question that we have that was sent in. Pre-existing cardiac disease, what special precautions, if any, should be taken?
Mm-hmm. So pre-existing, there are different kinds of pre-existing cardiac disease. Some are associated with outcomes that are not affected in pregnancy. Some are affected with adverse outcomes in pregnancy. I think the first key is to know. Once you're able to be aware of what actually your diagnosis is, then the proper intervention could be made for you to get the right treatment and right advice. We are recommending currently in New York City, if you're trying to conceive, to hold off for a little bit. There are people all around the world, as has been noted, there's not COVID around the world. Depending on what your diagnosis is, will better be able to craft what a proper pathway for you based on your diagnosis would be. So like if you have high blood pressure, you want to be able to be on medication that's safe in pregnancy. If you have valvular disease, there are different kinds of diseases. Some of them are best, most of them are best treated and addressed prior to you being pregnant, because when you're pregnant, it affects a lot of things and affects our ability to do anything if it's needed. So I would say the most important thing is to get screened, to have a proper diagnosis, and then to be triaged on what the best intervention would be prior to you going ahead to get pregnant. COVID.
Okay. Speaking of pregnancy, we take all questions here. Will pregnancy protect you against COVID? That's one of the questions we got.
So pregnancy does not protect you from COVID, but women who are pregnant do not get COVID more than the general population. Now, understand it's an infectious illness that is you obtain it by being transmitted by droplet infection. So pregnancy doesn't necessarily protect you, but you don't get it more when you're pregnant versus.
Okay. And there's another question I had here.
Michael, we took the pin. So whoever asked that question, just go back to Dr. Anyaga's first answer, which says she's also recommending, at least until more data is in, that if you're not pregnant now, don't bother run off and go get pregnant. It is not.
Okay.
So reinforce.
Yeah. Here's another question here. Can women positive for COVID-19 pass the infection to their unborn through the birth canal during delivery?
No, they cannot. It's not transmitted through vaginal secretions from the information we have at this point. Now, understand the guidance keeps changing. So as of now, CDC.
That's a question. Okay, what about sexual partners then? Can it be
transmitted? Again, so you cannot get it from vaginal secretions or semen. I know there's like a couple of case reports out there. The jury is out and they're still looking to it. As of now, you cannot get it from sexual intercourse. However, you can get it from saliva. So scenarios have arisen. So if you're having sex and you're kissing or having contact with someone who's positive, they can give it to you. Okay.
Well, if you want to say do that, I'm just kidding. But let me elaborate as well in that we have isolated the virus from semen, and there have been a couple of cases, and it's been all sensational. I think it's made some news
headlines.
Right. However,
okay.
That isolation.
I'm sorry. Go ahead, Nan.
That isolation has not proved to be transmission.
And
so there's a big difference. We can find a virus in many places. It doesn't mean that it can cause anything.
Okay. So, question.
Now, it could be in the hold on one second. It could be in the feces, okay? It could be transmitted by the feces. So if you have intercourse that way, it is possible that it could be transmitted that way. And so the recommendation is to use protection and to avoid transmitting it, because if you have oral, anal contact, then you can get it that way. So that's real.
Okay, question here. What about persons with blood disorder? Any special considerations?
Not really, no. Now, coronavirus is associated with some effects in the vessels that could be associated with clots. I'm not sure how else I can describe that. Thrombosis, which is clots in the vessels. So much so, actually, in hospitalized patients, just looking for these clots is almost routine. And so a lot of patients who have gotten sick, when they're discharged, they go and even when they're in the hospital, they're screened to see how much inflammation and or these clots they have. And based on that, they're put on blood thinners. So patients who have illnesses that could be affected by blood thinners could be affected because it's almost standard of care now to use anticoagulation.
Okay. What about women with sickle cell?
So women, so it's very interesting. Patients who have sickle cell have a lot of other comorbidities. So when they get affected by the virus, they're likely to get very, very sick. And they're also at risk for getting clots. So getting clots and getting COVID together just increases your risk of having an adverse outcome. So it would be a very terrible thing to have if you have sickle cell. The transmission is the same, yeah.
Yeah. Is there an increased risk of COVID-19 or its complications in women taking birth control pills or on HRT, hormone replacement?
No. It's not affected by birth control, and birth control doesn't affect it. What would be affected is the likelihood of you getting birth control because you got to go to the hospital to get it. So that's one of the things that we're hoping in the future we can change.
Let me say this, and I don't know, I should know this, and I'm embarrassed that I don't, but we used to be able to get birth control over the counter at one point in Jamaica. I remember Pearl back in the day. Do any of my women online know the answer to that? I do know that now, especially for, you know, the micro pills, we do the progestin only pills, we do have to write prescriptions, but I somehow in the back of my mind, I do remember being able to get Pearl just walking into the pharmacy. Let me say this though. We do know that birth control pills, as well as hormone replacement therapy, if you're on estrogen and progesterone, the progesterone portion does increase your risk of thrombus to a small degree. So there are some thrombophilic properties, right, tendencies of both contraceptives and hormone replacement therapy. And then if you have COVID, that we know also is thrombophilic, we would probably want to look at that closely, but there is nothing that says that we would either stop or pass.
Right. Okay, Dania, regarding that birth control pill question, I mean, that was an easy one. I can answer that. Yes, to a large extent. And but some women are going to need prescriptions. Actually, it was a pharmacist. We have a pharmacist listening.
Oh, good pharmacist.
Let me be honest. Yeah, but the answer to that question is yes. Some women are going to need prescriptions. I don't know which ones, but yes.
Right. It depends on the type of pill, like I said, probably.
Okay.
Right.
Yeah.
Thank you so
much. Question. Women, I understand, make up approximately 70% of the healthcare field in countries across the world. What post-COVID recovery systems do you think will be important for the female healthcare workers after the pandemic?
Well, that's deep. That's very interesting. So I'm going to start with vulnerable health systems versus non-vulnerable health systems. You know, as we know, the healthcare system in vulnerable countries, when I say vulnerable, I'm talking about countries that use or have less than 5% of their GDP attributed to healthcare, have systems that are not very secure, have conflicts in the utilization of funds, and in of a pandemic, the first thing to go historically is female reproductive services. That's the first thing to go. And, you know, in a lot of these areas that have vulnerable systems, you know, they also associated with poor quality indicators, including maternal child indicators, neonatal death, maternal mortality, morbidity, and such, you know. So there's an undue burden that eventually is not met. And then a conflict in, okay, should I, where am I, you know, you have to focus on the emergency of the day. And so you're going to see the outcome of when you shift limited resources that have a long-term impact. So you could end up seeing more kids dying from neonatal death because you don't have support programs, oral rehydration therapy, and in neonatal and infant infections. You have women's services because women are, maternal child programs often are not profitable in a lot of countries. So, you know, less attention being paid there. And as we know, in the pandemic, the population that's more affected are not female. So it's important for us to pay attention to these things that it is that are going to have had losses in support and coverage, and also figure out ways where the care can be more patient-centered so they don't have to rely on complicated systems to give primary and preventative care. I think that would be a very practical way to kind of look at it. And now in the other sense too, in developing countries or less vulnerable systems, a high proportion of the healthcare workers, and healthcare workers are vulnerable, are female. A lot of them are female. You have female, so the largest workforce in the healthcare industry is nurses, and nurses are predominantly female. Yes. So what are we going to do? They're at risk, they've been at risk, they're affected, infected. So you want to create a structure and get as much information as possible to understand the science of this, because the science is what's going to help us defeat it. You know, how does it work? Who gets protected? Who gets protected? What's the best way to protect them? We know PPE works. Is there a vaccine? How effective is it? These are the things that are going to prevent the next surge and or wave. Yeah. And I think time and attention to deal with that would be helpful.
Should pregnant frontline workers continue to be on the front line?
That was a question that we had to deal with. We have a lot of pregnant healthcare workers here in the system, and we wanted to make sure that we're not overshooting, undershooting, keeping them safe. The guidance does not suggest that pregnant women are more affected, and PPE works. Putting those two together, and practically I can say, if you exclude women of high risk, and you know, so if you have a high risk pregnancy condition that you've been managing and you are working, you need to just be out of that. But a normal, healthy pregnant woman who is keeping to the guidance can continue to work and has to be very, you know, in tune in her environment to understand not to put herself at positions that increase her risk. We have had our women working, and it's a very tightly communicated situation where everyone is kind of on the same page.
Okay, and quickly, can the baby be given breast milk?
Okay. Yes, if the mom is positive, we do breastfeed the babies with the proper precaution. They wear a mask and keep to hand washing to try to decrease transmission. Yes, we do.
Okay.
Good question, Michael, because I tell you, apparently we're not paying great attention to our chat. We're getting to it as fast as possible. So people have resorted.
I know if I sound as though I'm rushing, it's because there are tons of questions back here.
Yeah.
We might have to invite
I think we might have to do part two.
A part two, yeah. Go ahead. Did you have a question there quickly, Dania?
No, it was that pregnancy question. And then I did get the question about being a frontline worker and pregnant. And I will say that I actually know several, both physician and nurse frontline, and they're working. They're working. I mean, you know, I know with my staff back in the day, I would remind them that, listen, pregnancy is not a sickness. You know, we used to chop cotton and chop cane. You know, we drop the baby and go back. So you take the precaution, and like Chi says, if you don't have pre-existing conditions, and if your pregnancy is not high risk, that you would be increasingly concerned to observe precautions. And we can't stress enough, everybody should be observing precautions regardless. Hand washing, social distance. So it all is going to come back to sanitation and just being smart. And now if you're pregnant, you're being smart not just for yourself, you're being smart for two people. So you need more of your smart stuff.
And I have to mention the travel. So I think that in general, we are more a mobile nation now than we were in the past. So if you're pregnant or planning to become pregnant, not the best time to be hopping on a plane going places. Pilots actually contract COVID at a higher incidence than the general population. And actually, Pilots Association is going to be talking to the FAA about this because they feel that undue attention hasn't been placed to their protection. And so in the planes, usually if you're traveling now, you'll see the first 3 rows are going to be empty from behind the cockpit to decrease the aerosolization of, to decrease aerosolized particles from getting further across to them in the plane because of this risk. You shouldn't be traveling if you're pregnant. You want to limit that. You also don't want to be traveling to areas that the epidemiologic maps have shown are going to be have high prevalence rates of COVID. That's just something that you have control over. That's easy to do. I think coming, we'll get some more guidance from the main organizations, including the CDC. But that's something that you kind of, it's just like common sense, right? If you kind of take yourself away from a situation that could be, that is unknown. And in the airports now, when you go, like, you want to make sure you're wearing your mask, not touch. You remove yourself from the riskful populations, you're less likely to be affected.
Dr. Scenario, I know there's no short, comprehensive answers here, but I'm going to take one more question for you.
Michael, wait. People are going to kill me if you ask the wrong question. Hold on.
Sure.
Let me ask and answer this question before you get to your
Sure, go ahead.
Everybody, I've had this like 3 different times. What is the expected weight gain during this shutdown? Then I get another expected acceptable weight gain in capital letters. Let me tell you something.
As someone answer that one.
You know why I'm laughing, right? Go ahead.
As someone who has put out there, I was laughing with a friend and I said, I don't know if my 600-pound life is gonna just call for me or if I need to reach out to them. But this weight gain thing is serious. The struggle is real. The true answer is there really is no acceptable weight gain during this time. And so let me go back to what should be versus what I know is. So when I'm counseling people, I say this: your eating and your lifestyle should be mindful and purposeful. So there should be no variation because you are in the middle of a pandemic. It's really just a big life stressor. And if you are learning to eat in a purposeful way, if you're being mindful about your eating, you shouldn't be eating in response to being either bored, idle,
anxiety,
or stressed. And
anxiety,
so really, you shouldn't be gaining weight. And I would say to the people who say, yeah, but I'm not exercising as much. Remember that most weight happens in the kitchen. So things are formed in the kitchen and not necessarily just like the kitchen. So even if you're stuck in your home, even if you're in the Bronx or in Brooklyn, or if you're in Kingston in lockdown and you're not exercising like usual, control that with eating. Now, that's me telling you what should happen.
Now, what does happen?
Right. So here's a final question now, okay? This obviously is a new and a novel virus. A lot of what happens will be post. So the question has to do now with persons who are, do we know, or is there anything that can tell us if they're from infected, if someone's infected, if there is what sort of a potential birth defect,
So I just want to mention before we say that someone had asked of the infection rate in babies born to COVID positive mothers. So currently we only have a case series for the last 6 weeks. We don't have prior incidents to be able to guide us. And, you know, consistent, all the health systems kind of look at what's going on based on infection in women in labor and delivery. And in New York City, it's routine standard care to screen patients who come in. Over 75% of women who come in are negative. 25% are positive. And of the 25% that are positive, a very small proportion of them are symptomatic. Most of them are asymptomatic infection. They don't know that they're infected. They just come in, you do the test, and they figure that out. Now, almost all the babies that are born are negative. Whether they're born for moms, negative, moms, positive, everybody was routine screening. We don't know what we're doing, so we just want to screen everybody to find out. All the babies are negative. We have not had a positive baby yet. So having said that, you know, we don't have a true incidence, but the likelihood of a baby getting it from a mom being positive right now has occurred. We know that from case reports in other situations, but it's not a likely thing to happen. And because there's no vertical transmission at this point that we know of. So the question you were asking, Michael, what was the question you were asking again?
Okay, yeah, any birth defects possibly down the road?
Yes, so right now the information we have shows there's no vertical transmission and the baby is not affected in utero from the mom being affected who's pregnant. So we're not going to know until we follow forward from now in the next years what and if this does anything. So we have registers. Each hospital has a register of the babies that are born symptomatic versus non-symptomatic to follow the babies up. Now, I don't know if you guys are following the news, but what has happened is there's a peculiar kind of syndrome that is being found now in pediatric populations. Earlier in this disease, we found that kids were not affected. But now it seems like there's a kind of weird constellation of symptoms and aggressive inflammation that occurs in the pediatric population. It's not acute infection, it seems. This seems to have be happening in kids that were affected earlier. So they are positive COVID, they show signs of symptomatic involvement, and then for whatever reason they come in with abdominal pain or whatever, they have an extreme inflammatory response. That's what's happening right now, and we're still trying to get the detail of it, and I think we'll probably understand more in the next coming months. So we've changed the way we screen peds. When you come in for like weird abdominal pain and things like that, we try to whether you have this inflammatory syndrome because you have to be aggressive to take care of it. In New York City, 3 kids died, and we want to make sure that we get on top of it and it doesn't become a syndrome.
Okay, I'm gonna just now wrap things up here with asking you if you would kind of just give us your closing remarks. And I'm going to start with you, Dr. Mary, and then we go to Dr. Ball.
So I think this was fun. Thank you guys for having me. I think that we all have a lot to learn regarding what's going on with this pandemic, but it's important to understand that knowledge is power. I think we should all arm ourselves with the information that we need to make rational decisions. And I think on every level, as a personal and individual level, at a institutional level, a facility and systems level, we have to think pre and post-COVID. Post-COVID is going to be different. It's going to be a roller coaster ride. It'll be exciting, but I think if we all embrace and engage it, we'll come out stronger than before. And I think we've met some tremendous heart and wonderful people. I mean, I wouldn't take back some of the experiences I've had for anything. And so out of this, I think will be some positivity for sure.
Okay, thank you so much, Dr. Ball.
You know, like I said, my role.
Stay away from the kitchen.
My role today was facilitation and listening, and I learned so much. So I want to thank you, Dr. Anyago, for joining us, Dalu on. But also, just on a professional level, part of the reason that we do this and facilitate this is because in our region, we have a lot to learn and we have a lot to teach. And so we think that the magic of medicine really comes with continuous learning and a continuous exchange of ideas. And so we're really excited to keep doing this. We're going to expand our umbrella to bring in, you know, a lot more of our colleagues and friends who are having experiences in different ways, so that our practice in Jamaica can continue to evolve and expand and continue to just be on the cutting edge, where we like to be. So we thank you for joining us, and wow.
Yeah.
Twist your arm, because I'm sure I still see the chat button lighting up. We're gonna have you back for sure. But yes.
Yeah, would you please consider coming back again, because there's just so much that we could have covered that we weren't able to get to, okay?
Right.
And I thoroughly enjoyed you, as I'm sure I'm speaking on behalf of our participants here. And please stay safe.
You too. Stay safe. Thanks.
Thank you. Thank you.
All right.
Okay. Yeah. Dr. Ball, before you run off there, I want to talk about our next program will be next Tuesday.
Yes.
And we're going to be having that special guest. We're going to be having someone from a journalist will be here with us. We'll tell you exactly who that person is, someone who has been in the field and covering a lot on this COVID-19, and you know, it's going to be a very exciting program, I promise you. So again, let me just thank our doctors, all our participants. Thank you for your questions. Thank you for being a part of the program. And I'd also like to say thank you very much to my producer, Carrie Ann Evans. Carrie Ann, thank you. You were amazing. And we will see you again next Tuesday. Please be safe. I'm Michael Anthony Cuff, and I thank you so much for being with us.
Thank you.
Thank you.
Yay.